1 second, I'm gonna do it. All right, here we go. 3, 2.
Hi. Welcome to this virtual panel on structural competency in the era of COVID. Structural competency refers to the commitment and skills of clinicians, allied fields, and communities to work against health inequalities at structural levels. Through collaboration with community organizations, non-health sectors such as housing and law enforcement, and with policy.
Com 1 minuto. Antes que nós comecemos, por favor.
Already lost.
Por favor, un momento de silencio para todos los que murieron de.
Thank you. I'm Helena Hansen. I'll be your MC along with Seth Holmes. This is being recorded for posting at structuralcompetency.org, our website. Thank you to our supporters. Next slide. Okay, and then next slide. Tonight, webinar organizers will briefly describe resources available at structuralcompetency.org. The panelists will each give 5-minute updates about innovations and opportunities in policy and practice from around the world, and we will end with questions and answers. If you have, next slide, please. If you have questions for panelists, please write them using the Q&A button, question and answer button at the bottom of your screen. Our moderators, Kelly Knight and Francisco Ortega, will read them to panelists at the end. And now my co-host, Seth Holmes.
Thank you. My name's Seth Holmes. I'm a professor in Society and Environment and Medical Anthropology at the University of California, Berkeley and UCSF. And it's great to be with all of you here today. Next slide. So today we have simultaneous translation and interpretation in American Sign Language. We have closed captioning available at the bottom of your screen. We also have simultaneous interpretation in Spanish and Portuguese. If you want to hear the audio in English, go to the bottom of your screen a little bit to the right, click the interpretation button and select English. Otherwise, if you don't select an option, you'll hear whichever language the speaker is speaking in, which often will be Spanish, but sometimes will be, often will be English, but sometimes will be Spanish or Portuguese. Otra vez en español. Para escuchar el audio en español, haga un clic en el botón que dice interpretación o traducción abajo de la pantalla en la derecha y seleccione español. Si no seleccione, entonces va a oír el idioma en el que está hablando cada persona. And my Portuguese is not good enough to say that, but obrigado for being here. Next. We will also have a slide before the speakers to let you know if they're speaking in a different language, just so you know. Next slide. So now I'm going to introduce the first set of speakers who will be talking about resource sharing and network building related to structural competency. Next.
Hi everyone, I am talking today as a member of the Structural Competency Working Group. We are a group of healthcare workers and scholars who formed in California in 2014, and we now have members across the United States and internationally. We have been developing structural competency curricula ever since. You can read more about us at our website, structcomp.org. We just published all of our core structural competency training materials in MedEd portal, and you can access this publication on the front page of our website as shown here. Next slide, please. We want healthcare workers to think in structural terms. We highlight social structures that influence patient health with case studies as illustrated here and breakout sessions in our training. We introduce frameworks from social science such as structural violence, structural vulnerability, and what we call the naturalization of inequality. There is a training manual that accompanies our free training, slides, and material, and we hope that people can work with this material and adapt it to your particular settings and needs. Thank you.
Hi everyone, my name is Aloha Akpovi. I'm a rising fourth year medical student at Brown University in the United States. Next slide, please. So my peers and I developed a resource that we've shared on our website, and this resource is a case-based lecture curriculum featuring local map data in Providence, Rhode Island of different social determinants of health and health outcomes. And we developed it to train first-year medical students to define structural competency and to start to contextualize health using a systems level approach. It's meant to be introductory and widely adaptable.
Hi, I'm Janie. I'm a third year medical student at Toro, and I've been working on redesigning the structural competency website. Next slide, please. So we want the website to be a repository of training materials from all over the world, of people who have similar ideas and outlooks. So if you have training materials, whether slide decks or videos, you could send them to us at structuralcompetencynetwork@gmail.com, and we can put that on the website as part of the network, or any papers will go under publications, and there's also a link to join the listserv. Thanks.
Hello everyone, my name is Tinashe Koronga, and I'm from the Social Medicine Consortium Global Campaign Against Racism. So we are a network of health professionals, individuals, institutions, and organizations that advocate for social justice and health equity through social medicine education. And one of our main campaigns is the Campaign Against Racism, which seeks to dismantle structural racism and its effects around the world. And the campaign is organized around the 23 chapters across 10 countries that are part of the network, and anyone can join if you send us an email on listed on the page. So we hope through this, we hope to uncover the historical connections between racism and capitalism, so that we imagine a more equitable future. And as far as the COVID-19 is concerned, we are currently working on intersectional COVID responses with our various chapters. So for more information, please do visit our website. Thank you.
Hello, my name is Francisco Ortega, and I am professor at the Institute for Social Medicine of the State University of Rio de Janeiro. And I am a member of the steering committee of the Global Social Medicine Network, which co-sponsored this webinar. The network brings together scholars from all regions who are committed to a vision of social medicine as a vital intersection of social sciences, medical practice, and policy. Our network aims to rethink social medicine's past, to analyze its present, and to reimagine its future. The network was funded by a Wellcome Trust grant and launched as an international conference in London in 2018. It builds upon existing efforts to establish interdisciplinary programs in the medical humanities and offers a website to assemble an international group of scholars from social medicine centers across the world. The task and opportunity of the network is to reimagine the field of social medicine, showcase the diversity of approaches, and establish a truly global conversation to change the social and economic conditions that structure health inequalities. Thank you.
Thank you. So next we will have our first panelist on reproductive justice. That is Adsa Fatima.
Thank you. Hi everyone, myself Adsa. I work with Sama Resource Group for Women and Health, which is a feminist organization based in India. And Sama engages with issues of women's health and other concerns of public health from the lens of gender, human rights, and social justice. Next slide, please. So today, since we are all facing this unprecedented crisis that has brought us together as a global society, and I'm going to be talking about within that presenting some of the issues from this region and what Sama is really engaging on. So what we are witnessing really is, the reinforcing of the structures of inequality at this time, and global pandemic, which started like a health concern, and one would imagine that it will affect everyone equally, but well, it is not. And it is not just the pandemic, but also the responses of the government that tend to, build on and overlook the rights of the marginalized groups, populations, and vulnerable persons um, from varied identities and locations. So what as Sama, because our work is located at the intersection of health, gender, justice, what we are really seeing is trying to connect this intersectionality of gender, justice, and health. And we are naming it COVID Canvases to really understand it. And the picture that you could see there in the slide, it's really a snapshot of, when the lockdown was enforced in the country. That's a long queue of migrants who are urban poor, and they stood in queue to go back to their homes in villages, as they had immediately ran out of resources to sustain their livelihood in the cities. Next slide, please. Okay, so very briefly, some of the current crisis engagements is we are collaborating with the public health networks to really input into the government systems and protocols and keeping in mind, because we as part of our work, we have been engaging with these systems, with the health systems and policies, that the systems are weak, of course, in terms of public health infrastructure, and weak systems are also always gendered. So to really, amplify the voices from the field. So we are engaging with the community in terms of crisis, trying to communicate with them, bring up the cases of violations and raise them as issues, and raise, then preparing policy briefs and issues and public statements, and then raising it with the government, because every day new orders and new protocols are being set. So that's where we started really engaging on. And then what we see this also as an opportunity this time, and it has, brought out that with sexual and reproductive health and rights particularly, immediately the reality of reproductive services being non-essential, and then, the struggle to, because during lockdown other health services were just suspended. So challenging and raising the issue of that the everyday violations of women, their race, caste, in a pandemic, it should also include, look at health comprehensively and structurally. So we are trying to connect those critical connections between socio-political determinants of health, while we are in a context of a universal and global pandemic situation. Sama has also started helpline services, as we also work on the issue of gender-based violence. And like several parts of the world, in India also we saw a surge of... In India also...
Consegui, agora eu só estou procurando aqui o local.
In India also we saw a surge of domestic violence and other forms of gender-based violence. So somehow we started helpline, and there's also need to understand newer, forms and vulnerabilities, because now with streets becoming deserted and with quarantine facilities and isolation, to really not just homes, but we are also seeing that it's very important to talk about safety and, our public spaces, including hospitals and all these facilities, also being gender sensitive, and recognize the vulnerabilities that these isolated spaces carry for women and girls. We are also providing, as crisis management, we are looking into providing protective equipments to community at the community level to healthcare staffs. So that's been sort of a immediate, because that's another shortfall that we are seeing here, and something that is familiar, I think, right now to varied healthcare workers across the world. Next slide, please. Okay. So what are some of the, so we are talking about structural competencies, and it's fascinating because this time is so unprecedented, and the way it has laid bare the inequalities that exist around us, almost the imagery as that picture of migrant workers that I showed you from India, and several other pictures, inequalities becoming very real. We really need to look at the structural changes, and I will just start with the first thing would be the health system, really retransforming the health system. So it should not be just about adding more resources and strengthening public health system, which is the main location for a lot of marginalized group who cannot afford private care today, at least in the context of India. But at the same time, strengthen, because on your normal days, sexual and reproductive health services are weakened, so they automatically become a crisis when it becomes a pandemic. So for a SRHR, sexual and reproductive health rights and a reproductive justice would require a strengthened system in terms of gender structurally. Then at the same time, quality healthcare. Quality remains an alienated concept when it comes to marginalized women from marginalized location. And today in pandemic, we are talking about better life, better quality, and reducing morbidities. And reproductive morbidities are so much unknown. So quality healthcare should be really pushed within the rights framework, and it should be for everyone, notwithstanding their financial capacity or affordability. Then, of course, addressing the gendered nature of the health workforce globally, as well as what we see in India, that 70% of of it is women, but within that hierarchies, and recognizing them, their potential as workers, especially primary healthcare workers in the context of India, that becomes a very strong, and as I can hear myself, I've said India a couple of times, so that was another point that, for countries of this RECAT, that within the policy is more contextual to the need, because the inequities, their forms and their expressions are different, and so it should be revisited, keeping the most marginalized in center and their needs. For instance, India would think about whether it want to only look at tertiary healthcare system, or should it be strengthening its primary healthcare facilities, so that remote location can also be looked into.
Okay, thank you so much. Thank you for that terrific update. I would like to let the group know that we're taking a small pause for the Spanish interpreter to change channels, because the quality is not what we would like. The other thing I'd like you to know is that we invite you to post questions as we go in the Q&A box. There's a Q&A box at the bottom of your screen in the center. So please do use that. Vamos a pausar. La intérprete español tiene que cambiar canales. Si tiene preguntas, usa Q&A. Gracias. All right, so I'm going to ask, is the Spanish interpreter Saudi active?
Yes, I'm here.
Okay, so now we'll continue with reproductive justice. Monica Camor.
Mónica Camor. McLemore.
Good morning, everyone, and I'm really glad to be here with you. Next slide, please. So prior to wanting to have any conversation about human rights or reproductive justice, I really think it's important and necessary to actually define what that means. Because I do think that there are foundational definitions that have been put forward by founding mothers of reproductive justice. And I definitely want to shout out. I'm sorry, I'm actually being able to hear the Spanish translation. Should I pause?
I think you should continue. Thank you.
Okay, thank you very much. Prior to any discussion about discussing reproductive justice, it's important that we acknowledge from which it comes. And so I want to say two things. First of all, the images on this slide come from the Repeal Hide Art Project and a good colleague and collaborator of mine, Megan Smith, and I have permission to use these. And I highly suggest you visit her website, because she's created beautiful images to represent the fundamental tenets of reproductive justice. I also need to sort of shout out our elders and folks who created reproductive justice in 1994 in Chicago. And it was 12 Black women scholars who really thought that reproductive health and reproductive rights was too small and not comprehensive of enough of a frame to really be able to talk about the complex issues that surround people with the capacity for pregnancy and the communities of individuals who support them. So shout out to the founding mothers of reproductive justice, who really saw that it was necessary to align social justice with reproductive health and reproductive rights to really develop a human rights framework to understand how we should organize health services, how we should create health policy, and how we could actually achieve health equity. Fundamentally, the tenets of reproductive justice are quite simple: that people have the human right to be able to birth and to determine the conditions under which they will birth. And that's a really important context to understand, especially in the context of the pandemic. The second tenet of reproductive justice is that individuals have the human right to prevent or end pregnancies in ways that they determine and see fit with dignity. The third tenet of reproductive justice is that people have a human right to parent the children that they have with dignity, without fear of violence or without actual violence from any individual or any state or any government. And this has huge implications, not only for individuals, as we previously heard from the speaker, specific to intimate partner violence, but it also has implications for individuals who experience incarceration and war, famine, and other types of disasters. Finally, we like to think that humans have the human right to disassociate sex from reproduction and to really be able to understand healthy sexuality and sexual reproductive health as a comprehensive component of a whole human life. In other words, it allows us the opportunity to talk about everything from consent to pleasure to healthy sexuality. Next slide, please. This comes from our colleague, Rashawn Ray at the Brookings Institute. And I think it's really important that we think about reproductive injustice in the time of COVID. So I have to say that, you know, one of the things that's most interesting about the novel coronavirus that has manifested multiple organ involvement that to date has killed more than 2.6 million people around the world. But this is a global pandemic, has not only shuttered the economies of multiple countries, but it has exposed long-standing inequities that are associated with structural racism and strategic divestments from critical public health infrastructure. You know, consistent with our previous speaker, I will definitely say that this pandemic has laid bare core issues that, in my opinion, intersect the social, clinical, and the structural determinants of health. I mean, it is within this context, and as in all other contexts, even pre-pandemic, that reproductive health rights and justice always serves as the canary in the coal mine. And I have to say that we've heard not only documented, but also anecdotal accounts that inform consent, reproductive autonomy, and the basic principles of health equity are being violated due to the need to balance scarce resources and to flatten the curve, which is an important public health principle. And at the same time, it totally makes sense that pregnancy and childbirth would become the ground zero, at least in the United States, for where these violations would occur, since childbirth remains the primary reason in the United States that people are hospitalized each year. I'd like to remind the viewers of this webinar that prior to the emergence of COVID-19, we already were in the midst of a Black maternal health crisis, which had been well documented. And in fact, some of the expansions that we've seen during COVID-19 actually that we have been fighting for have actually been operationalized due to a pandemic. Let me give you a couple of examples. First, prior to the pandemic, despite national licensures, clinicians could not work across state lines. And now we've been able to do that because of the pandemic. I suggest we make that permanent. The Centers for Medicare and Medicaid, which pays for half the births in the United States, would not reimburse for telehealth visits prior to the pandemic. I suggest we make that permanent too. There's also discussions, and I'm sure my colleague and collaborator, Saraswati Beedam, who is coming up after me, will talk a little bit about auxiliary maternity units, or places where people can birth outside of hospitals or receive prenatal care. COVID-19 has removed many of these barriers. However, one of the things that I really, really want to be able to highlight and for us to be able to think about is the Monday before the United States went into full shelter in place, the Black Health Caucus, Black Maternal Health Caucus of the 116th Congress of the United States introduced the Momnibus, and the lead authors were Representative Alma Adams of North Carolina and Representative Lauren Underwood of Chicago. And that 9 bill really put forward many of the things and many of the recommendations that we should be using to really be able to maintain human rights in childbirth and pregnancy as we walk through this global pandemic. Thank you for having me.
Thank you so much. And next we have Saraswati Beedam.
Good morning. My name is Saraswati Beedam. I'm a professor of midwifery at University of British Columbia. I'm honored to be with you all and grateful to be coming to you from the traditional and unceded territories of the Coast Salish nations, that is the Musqueam, Tsleil-Waututh, and Squamish nations. Next slide, please. I wanted to talk to you today. Thank you, Monica, for paving the way. I want to talk to you today about what's happening around the world when communities and people who are giving birth or anticipating giving birth are considering the possibility that they will be exposed to COVID-19 if they go into their clinics or hospitals where they were planning to give birth. They're understandably worried. It is incredibly worrisome time all over the world. And because of that, there's an increased demand all over the world. And we're talking about India, the UK, Netherlands, the US, Canada, Indonesia, all over the world. People are deciding that facility birth is not this time. There's a scarcity of care providers due to diversion of care providers to care for COVID sick people. And there's an evolving evidence basis for how childbearing families should be cared for. Unfortunately, there's no local consensus on containment strategies, and social distancing in institutional settings it's just not set up for that, and certainly not in low and middle resource countries where the in all hospitals are not set up or able to have the kind of space that you would need in order to do that. That's also true for people who live in shared or unstable housing. And in the midst of this, there's inadequate PPE guidance, there's personal protective guidance or allocation to either communities or to service providers. This is all an incredible setup to an increase in violations of human rights. We've heard them all over the world about people being told they need to apologize before they get tested, before bringing the virus to their, if they look Asian at all, that's the kind of thing. If they're Black or brown, if they're poor or young, they don't have they never had equitable access, and they have even less access now to the kinds of care that they need. And this is all in the context of the fact that specialists are recommending separation from well from sick. Next slide, please. I want to give everybody a sense of what it really looks like. This is a maternity unit in the Philippines where people who you can see who are yet to deliver, who are in labor, who are postpartum are all together. There's no possibility of social distancing in this kind of situation in the institution. Next slide, please. We have studied this, and we know that even without COVID, that overall in high resource countries, you're seeing 1 in 6 people experience mistreatment. And by mistreatment, I'm talking about very serious things: being shouted at, being scolded, being verbally abused, being physically abused, your request for help being ignored. We know that when you look at just Black and Brown or people of color, people who are who have lower resources, people who have comorbidities or things that might make them more vulnerable, that rate increases to 2 to 3 times as much. So we're talking about 2 out of 6. And interestingly, that is data that comes from high resource countries. In the same year that we published that data, we also have had an amazing article in The Lancet with 4 low resource countries that have the highest population of birthing families, and they found the same rate, 1 in 3. Next slide, please. So the point is that we're all in the situation that right now we need to pay attention to what communities have been telling us all along, and that in fact their needs aren't being met, and these huge inequities are being addressed not by health systems, but by communities themselves. This is a time when actually we can learn from low resource and from community-based strategies. I spoke yesterday with an Indigenous midwife in northern BC who was very, very frustrated. She said, we have been asking for telehealth for many, many years, and they always said it was too hard, too difficult, too expensive, can't do it, people won't use it. And overnight, when it became an issue for the dominant culture, overnight they were able to put telehealth in. And so she understandably feels very disrespected and very and that's only one example of strategies. We've heard about doulas task shifting their roles to take food, to do doula care, to do COVID testing. We know that midwives and community health workers in India are extending the healthcare system. So since we know that there are systems that exist, we know that there are people who are quickly shifting or having a rapid response, and they're being more efficient in it in the community. We decided to pull together a global perinatal task force to try to bring all of this wisdom together. We're not trying to reinvent the wheel. We know what to do. We know that human rights have to be front and center, because that is health and well-being and good outcomes. We know that we have the competencies to deliver care in a low resource setting without all the bells and whistles and still preserve safety. We know that we can mobilize our community experts, our community-based organizations, our elders to help that. And they have already established rapid response birth units. So we've put together this we're putting together this repository. We're working with 200 people from around the world, and we welcome you to join our effort. We hope to have it launched in the next couple months in a multimodal way, accessible. Thank you.
Thank you very much. Just a reminder that we have simultaneous interpretation in English, Spanish, and Portuguese. We're doing our best to make sure that it all works. We also have simultaneous interpretation in ASL, and there's closed captioning available. So if you want to hear the presentations in English, please go to the interpretation button at the bottom of your screen and select English. Otherwise, you'll hear the language that the speaker is speaking in. Also, if all the speakers could do their best to speak a little more clearly and a tiny bit slower than they're used to, that would be wonderful, since many people on this call are working in their second or third language. Thank you. So the next panel focuses on media and framing, and our first speaker is Charity Emihil Bartels.
Good afternoon, and I'm a journalist, communication strategist, and also the founder for Emihil Transformation. And so basically, we're just a group of mothers over here in the country, and we're trying to see, we frame the narrative and also change the conversation, just the COVID-19 and how it is being recorded in the country. So basically, Emihil Transformation, we're a non-governmental organization, and we're focused on training and then also building the capacity of people in underserved areas of the country, especially focused on children. We are geared towards realizing that there is the need for providing of skills, especially for people who are also in such underserved regions in the country, and also Africa as well. With the advent of COVID-19, if there is anything that it has taught us, then it is that people are still holding on to issues of stigma and abuse of people who have been who are falling victims. Next slide, please. Next slide, please.
Charity, the sound quality is a little bit poor. If you're able to reposition.
Okay. Okay. Is this better? Is this better? Can you see?
Yes. Thank you.
Okay. All right. So if you could go to the previous slide on the stigma and abuse against children of persons with COVID-19, I'll be grateful. So we've realized that as the pandemic rages on, there are certain issues of societal concerns that are also raging. And these are issues of stigma and abuse of persons with virus. It has become of great concern for us at Emihil Transformation because we realize that most of people who are affected by the virus are children in the society. So we find it's very difficult to realize that a lot of children are being isolated and they are not really able to be accepted back to society. And so we decided that we need to take a step in inculcating these children who have been affected by the virus, directly or indirectly. And so that is why we came up with a campaign of wanting to end stigma and abuse of children, of persons who have been affected by the virus. Next slide, please. Thank you. So what you have on the screen are some simple materials that we have developed to share out to our friends in the media. We're trying so hard to get the media to really channel a lot of conversation towards ending and eradicating abuse and stigma of children, of persons who have been affected by the coronavirus. Over here in country, we've recorded over 2,719 cases, and so the numbers rising by the day. It is something that is really affecting us, and especially the children have been home for over a month, so a fall back to society has gone off. So a little is being said and a little is being discussed by the media over here. So what we are trying to do with this campaign is to ensure that the conversation, majority of the conversation is given and attention is given to the children who are being affected directly or indirectly. So my partners, Ash Women's Foundation, we're also seeing a change since the campaign began. And we've realized that it is beginning to get momentum in the media landscape over here. And I'm so happy that over the weekend, on Sunday, during the Press Freedom Day, a lot of conversation was being had in the media landscape, especially with regards to ending stigma and abuse of persons who have contracted the virus. You see, one thing we need to understand is that it's a different thing to be affected by the virus, because the trauma, the emotional pain, the frustration of a person to be told that you are positive of the coronavirus is enough to shatter a person's psychological status. So to overcome the virus and come home only to be faced with issues of stigma, the society that you once called your home is now running away from you. We've had stories where a survivor came home, went to the barbering salon to go and have a haircut, and the barber told him point blank, my light is out. But he could see somebody in the shop who is being attended to, their lights on, the light. This is how bad issues of stigma in the country has gotten. And that children are even scared to go out to play because you have grown-ups or telling them not to come and play with their children because their parents or their relative has been affected by the virus. Next slide, please.
Thank you, Charity. We'll need to wrap up in a minute.
Okay, so briefly, this is what we are doing. We're trying to provide one mask for each child in the hotspots areas identified, and we're trying to see if we can rally up all supports to get one mask, at least one reusable mask. And you know, over here we are bent on our fashion. So you have tailors and stressors who are coming up with fabric and nose masks. So we're trying to rally support and get a lot to distribute mask to children in the hotspot areas across the country. We've already done a lot. So we're also reaching out to a lot of people over here to see how best we can get a lot of these masks for the children, and also hand sanitizers for them, and also go out there and tell people of issues of stigma and how it can assist them. Thank you very much.
Thank you very much. Our next presenter is Ana Lucia Pontes.
Thank you for the opportunity, and it's a great opportunity to hear the presentation, share with you some information about Brazil. We are in this point in Brazil in an increasing amount of cases. We have reached around 8,000 deaths and more than 100,015 cases confirmed, but those numbers are very underestimated. I represent here the Brazilian Collective Health Association. I'm also a researcher from the Oswaldo Cruz Foundation. Oswaldo Cruz Foundation is in the front line of the implementation of several actions supporting the Ministry of Health in Brazil in the COVID pandemic. Next, please. So our entity, it's an entity that reunites researchers, health professionals, students, social movement representatives, and it's an entity that was created in the context of dictatorship in Brazil in the late 70s. And this is important for our discussion because this means that since its foundation, it's an entity very committed with the discussion of structural change. So the discussion of health as a human right and the struggle for a universal health system is the core of this organization. And at this moment in Brazil, we live a very hard context in a militarization of several institutions, including the Ministry of Health and the health services. And in the context that we have an authoritarian manner of managing health policies, and in which we are in a very strong movement of advocacy for structural change. Next, please. So this is the organization. So I think it's very secure to affirm to you that Abrasco is very committed to discussions that are related to the structural, like social determinants, like social inequalities and economical disparities that are in the bottom of health conditions, and that health changes, and that facing COVID pandemic is strictly related to those structural conditions and that are in the basis of Brazilian reality. So as an example, this slide is some points that in the right side, I point out some of our public notes to say some kind of discussions that are related to the structural change that we are discussing. The first one is related to a very important attack that we are having in scientific institutions and financing for science, and sciences as a base, an important basis for health policy formulation and implementation, and in a turning point where also social sciences and human sciences are being attacked. And though this is a very important moment to show and evidence the relevance of social science and social medicine for thinking and implementing measures for COVID pandemic. Another group of questions that are emerging in this context and related to social disparities are related to different ethnic identitary groups, related to gender issues, and related to racial issues that are the most vulnerable groups in the context, and that they suffer as well with some kind of lack of opportunities to discuss directly with the government the strategies and implementation of the best strategies for containing the pandemic. So we have this note, for instance, for LGBT population in the context of pandemic. And we also have a request for more evidence of the race color information and health system in this context, so we can discuss the racial disparities in Brazil, inequalities. Brazil has a racist society as well, and in the response to COVID, we don't see much discussion related to this difference and this disparity. So our entity is trying to put in evidence those debates that are also in the basis of discussions of epidemiological surveillance, of implementation of diagnostic strategies and health actions. It's very important also to say that we are engaged with discussion the health system, which in Brazil is a obligation of state. So this has been many measures that put in risk this public health system and the state responsibility. Just to end, the next, please. We are very engaged in, next slide, please, in some platforms to provide those information and discussions. Here I show you 3 specific platforms, one for scientific information, one for official notes from Abrasco, and the other one is a YouTube channel for discussions for broadcastings and information. Thank you very much.
Thank you. The next panel will focus on indigenous mobilization, and the first speaker will be the same person, Ana Lucia Pontes, now speaking about indigenous mobilization.
Thank you. I am a part of a research group in Oswaldo Cruz Foundation focused on indigenous health. And in Abrasco, we also have a working group, Indigenous Health, that gather researchers from all over Brazil, from different institutions. At this point, we also have a very strong discussion related to the need of gathering indigenous researchers and creating a community of researchers where indigenous peoples also have a protagonism. Next slide, please. Just some very few informations. Brazil have around 900,000 peoples, indigenous peoples. We have one of the most diverse ethnic groups in Brazil, with 305 ethnic groups and 274 languages. But we have a very persistent health and social inequality and violence and injustice that in the context emerges And actually this government right now, Bolsonaro government, has a very clear frontline attack with indigenous rights. And so just to show you that indigenous population in the left side, you see they are all over Brazil, despite the fact people think it's only in Amazon when we say indigenous people. So we have indigenous people in isolation, we have indigenous people in indigenous territory, indigenous people near cities, and we have indigenous people living in urban areas. But in the middle, the map in the middle, see how this people is confined in very small territories in the northeast, southeast of Brazil, and the most indigenous territories are in Amazon. And in the right side, you see a map that we have in Brazil, a specific health system for indigenous population. Next, please. So in the context of COVID, we are doing a very strong advocacy work to debate the multiple vulnerabilities that indigenous peoples are submitted, and therefore we have to, in our strategy in Brazil, have very specific and some kind of a prioritization to elaborate strategies for these people in this different context, and also discussing the other threats that they are having, because nowadays we have an increasing of deforestation in Brazil and a very clear direction in the government to attack the indigenous territories. So we are providing debates and documents to strengthen this debate. Next, please. Next slide, please. But I would like to emphasize the indigenous protagonism in this debate. On the left side, we see a very strong strategy for a national organization called Articulation of Indigenous Peoples in Brazil. They have a specific platform for information, public notes, and also for monitoring case, because there is a huge dispute right now in monitoring indigenous case. The government only point out indigenous case in indigenous lands, and they kind of ignore the indigenous case in urban area or people who are not living in indigenous lands. So the organization is in this discussion right now and organizing several debates, online debates. We are having the next few days a huge assembly, online assembly, to discuss a national organization for indigenous people related to COVID pandemic. And they are very, very active in this online mobilization. And on the right side, you can see at the top, we have at this moment the first indigenous federal deputy, Joênio Apixana, and she's leading a front line with the opposition in the Brazilian government to discuss with governmental institutions and also with indigenous organizations strategies for indigenous people. And they are actually this day, today is gonna be the day they will discuss a bill, a specific bill in the Congress for indigenous population facing COVID. In the bottom of the slide, I want just to sign out some of the huge initiative that they are having also to develop, to access information, because the governmental information and media information is in a language that's not sometimes understood and don't reach the channels that they can access. And also they are facing a very huge struggle for survival, because social isolation implies sometimes in facing hunger, because they do not have enough land to provide food for themselves. So they have a lot of humanitarian campaigns at the moment. So that's the scenario. Thank you very much.
Thank you so much. Another reminder, if you want to hear the audio in English, click the interpretation button at the bottom of your screen and select English. Otherwise, you'll hear the language that the speaker is speaking. And the next speaker will be speaking in Spanish. The next speaker is Marcela Castro Garrido. Thank you for joining us. Marcela, are you there?
My name is Marcela Castro. I'm an anthropologist. I work in the Medical Center of the Universidad Católica. So I will be discussing initiatives for resistance in front of the COVID-19 pandemic. Next slide, please. So COVID-19 arrived as a foreign illness. And so this resistance initiative that we have, I would like to tell you a little bit about it. So I would like to tell you some of the initiatives in the public health centers. The initiative that we have is how to fight coronavirus in the indigenous language. So we're focusing on access to information in indigenous languages. There are also some initiatives from the public health center have access to this information and also to understand how from the indigenous world this illness is conceived. So on the right we have information of how some people of the Mapuche ethnicity are thinking about coronavirus and what it implicates. I also wanted to discuss some of the organizations and initiatives that are also in place because indigenous communities have also taken the initiative of information in the indigenous language. So that people can understand, especially information around how one gets sick from coronavirus. Next slide, please. As you can see from the previous images, there's information on how to use the mask, how to wash hands, and also how to use water well. In the state, there also have been some initiatives
entre la naturaleza y algunas y el cómo se fue prediciendo lo que iba a suceder.
And so there also is a conversation about thinking about nature and how it was predicted that these things would happen. The shamans, the people who are in charge of religious practice in the indigenous world, augured that bad things were coming for this period in time. There would be illness and poverty. So in some way, shape, or form, we were already informed that something would happen. And on the other hand, so something that is very vital to us to thinking about autonomy is territorial control. What we've seen is that routes are getting cut off, rural access is being challenged. So indigenous communities have attempted to say that they are autonomous territories. What we've done is call out and ensure that the routes of access that have been shut. So we have done a territorial control by shutting down the routes to tourists. So people are organizing themselves to do territorial control. Aside from these moments of resistance in the indigenous world, there also have been
Next slide.
moments of collaboration. So there have been economic problems that have surfaced with the quarantine that we're living here in Chile. People cannot bring their agricultural products to the city. So there has been a call for solidarity among people. What we have done is create a series of campaigns to be able to survive this quarantine in the best ways. There have been campaigns for how to eat well, different campaigns to support the community. There have been other activities that have allowed us to deal with the quarantine. We have seen that indigenous film producers have given free access to their films. These are some of the initiatives that we have. These are some of the initiatives that we have. Thank you.
Mil gracias por presentar a nosotros. The next panel focuses on grassroots public health systems creation and strengthening. And the first two presenters will be John Lasher and Baylor Berry.
Thank you very much to all the organizers and hosts. We're very happy to be joining everyone from Sierra Leone. My name is John Lasher. I'm the Executive Director of Partners in Health Sierra Leone, and I'm joined by so a little bit about Partners in Health. We're a social justice and health organization that was founded over 30 years ago in Haiti. Since then, we've expanded our work in countries around the world, and we make long-term commitments to the places where we work. We've been in Haiti for 35 years, and so when we make a commitment to support the most vulnerable in a country, we stay for the long term. And we, when we do make these commitments, we're also not a contract-based organization. So we come in, we make a long-term commitment, and we have no exit strategy. This is because a lot of the international aid that exists around the world is very short-term and contract-based. And we'll get into a little bit about that in our brief remarks. Next slide, please. So in 2014, at the height of the Ebola outbreak in West Africa, Partners in Health was asked to help respond to Ebola in Sierra Leone. And PIH, which is short for Partners in Health, had never been working in West Africa at that point. And we decided as an organization that we were going to help the country of Sierra Leone respond to Ebola, because we know as an organization the best way to respond to emergencies is to invest in health systems strengthening. And what we found during the Ebola outbreak is very similar to what we saw during the earthquake in Haiti in 2010, the cholera outbreak in Haiti in 2010, the HIV epidemic that swept through large swaths of the world in the 80s and 90s and still persists today. That is, the attention and the focus on these emergencies last for a very short period of time. And then governments, countries, and donors move on. And in Sierra Leone, during the height of the Ebola outbreak, 99% of all people that were in the country of Sierra Leone never had Ebola. Before Ebola, Sierra Leone had the highest maternal mortality rate in the world. Before Ebola, it had some of the highest child mortality indicators recorded in the world. It had the lowest life expectancy for men and women in the world. These were all true before Ebola, and they're still true today. What Ebola exposed was how weak the health system in Sierra Leone truly is. This is following decades of colonization, a slave trade, the Civil War, and that all led up to the Ebola outbreak. And there were some systems that were put in place during the Ebola outbreak that are serving us well during the coronavirus outbreak now. What we decided as an organization was that we had to address the immediate need for getting Ebola under control. So we partnered with the Ministry of Health and Sanitation in Sierra Leone, and we helped support 16 different Ebola facilities around the country. Sierra Leone has been prepared than many countries in the world for coronavirus because of the triage systems that were set up, because of the training that people had in terms of social mobilization, the amount of education and communications campaigns that existed in the country. All of the practices that people learned during the Ebola outbreak are applicable during the COVID-19 outbreak. But what is clear during this COVID-19 outbreak that is similar to Ebola is that the investments that are being made around the world during the COVID-19 outbreak are not coming to cities like Sierra Leone. And in the news, at least in the American media, which occasionally I look at because I'm an American, it seems like there's a narrative that Africa is going to be spared from COVID-19, or at least the worst of it. But I think many of the presenters who have preceded us can attest that is just fundamentally not the case. Even if case numbers remain low in sub-Saharan Africa, the most vulnerable people on earth are in places like Sierra Leone. And schools are now shut. Lockdowns are being ordered in places where 60% of the population are unable to put food on the table. So what we're recommending is that organizations make long-term commitments to help rebuild health systems so that it's not just tents and facilities that look like this picture. Next slide, and we're going to wrap up. Thank you.
Yeah, so thank you, John. John basically explained like the system that we are put doing Ebola helps like in the country to have a foundation under which they will build their coronavirus response. And basically what they did, they kind of like shut down the country early, which was great, like stop all foreign flights from coming into the country, and like shut down international boundaries, and then activated all the structures that were put in place during Ebola. Was active emergency operations center. But John made it clear the major problem with the country's response is resources. We have all the systems, we have everything in place, but there are minimal resources to implement them. So what Partners in Health is doing right now is like we're approaching it in two ways. One, in the district we are working, Cornwall, we have a deep dive approach there. And then nationally, we're also supporting nationally the contact tracing efforts, the case management. So in case management, we have our our medical director basically attached at the main treatment center, helping train clinicians and treating patients. And in terms of case management, in terms of, and we also give them some resources, but in terms of contact tracing, what we did was we designed a strategy to be implemented across the whole country, where about 1,500 contact tracers were trained across the country and then deployed. Currently, we're trying to work on how to deploy and implement that program. Whereas in Cornwall, we were working there, we designed like a proper triage system, a two-step triage system in the hospital. And we also trained a bunch of community health workers to be social mobilizers. They go to the community, do house-to-house education, and identify cases and then refer them to a facility where they can be tested and treated. So apparently, in a nutshell, this is what we do. And also just want to say the country is struggling to do a total lockdown, because of the resources. Over 70% of the population live day by day. And if you shut down the country for 14 days, how are those people gonna live? So that's a big problem. And like the resources are not there to support those people while there's a lockdown. Thanks.
Thank you. Thank you very much. Our next presenter is Gabriela Di Croci.
Hello, can you hear me?
Yes, we can hear you.
Good afternoon, everyone. My name is Gabriela Di Croci. I'm a family medic here in Argentina, and I belong to a group, which is the Huayna Kai movement. It's a term in the Quechua language, which means health. And this is a movement that links young medics, family doctors, and as a movement, we depend on the Confederation of Family Medics SING. I'm grateful for the opportunity. All these presentations have been amazing. The thing that I wanted to share is that beyond the number of panelists and the difference in geography and that we don't know each other, there's an incredible line of continuity in all these presentations. And so I think this is something that we need to also think as something positive in this response to COVID-19. In the first part of this presentation, I will not have positive areas, but I will have, I will resume in words and share. Our organization has worked in a similar way than others that have been presented. And the first thing that happened in our response to COVID-19 is that we united. We're family medics and we belong to 14 regions of the Latin American continent. We have 14 regional coordinators, and we organize virtually with the desire to work on our strategies to bring health to all in our communities, which is one of those principles of medical attention. And one of the principles we have is never failing to support each other amongst ourselves. Family medicine is one of the practices that works most closely with populations. Because the first area of attention is not the hospital, but the peripheral medical centers. So our primary response to COVID-19 has made it so that all the efforts are directed towards hospital work. And it doesn't mean that we don't recognize the importance of hospitals. We cannot forget that beyond COVID-19, there are many, many health problems, gender violence, family violence, poverty, hunger, chronic illness, family planning, unwanted pregnancies, pregnancy interruptions. So we still have to guarantee the health of those communities, which is one of the primary missions of primary care medicine. So what has made us, COVID has made us rethink how do we do this work so that we not only manage what illnesses that COVID causes, but also what needs to be done in the other health centers. So what we've noticed is that redistribution, a closing of peripheral health centers, redistribution of medics, redistribution of all the employees. Those folks have been redistributed to give attention to the zones where COVID has impacted. We believe it's an opportunity. COVID-19 is giving us the opportunity to rethink the space that community medics occupy. And that includes also all the health professionals that I've also mentioned. So we're rethinking in the face of the local, national, and global sanitary strategies. It really depends on how each community articulates our health system, but we really articulated the importance that we have as a community, as part of the health system. We want to be able to be closer to the spaces where decisions are being taken for families and communities. Especially because we have a particular vision that we want to share, and also to listen to the needs of the community. For this presentation, I've taken many of the things that I have heard since it began. And there's a theme of hope because there are many of us, many places in the world, attempting to figure out how to manage this craziness that is COVID-19 and manage the loss of patients and friends and even colleagues. We have to emphasize the importance of the opportunity that we have now to put on the table questions that have been forgotten, and so that the work of health isn't centered only on the hospital task, but that also can be directed towards other sectors that are badly in need. And that we are walking and really thinking about the needs of the communities and put on the table health questions that are often forgotten, and that right now they are completely overshadowed by the needs of this respiratory illness that's COVID-19. I won't say much more, but it's an opportunity for primary care, an attempt for primary care to regain its role in health systems around the world, that we have much more equality and we have much more equity, which is necessary in this moment.
Mil gracias. Thank you very much. Our next presenter is Wani Michael.
Hello, everyone. My name is Wani Michael. I'm the Executive Director of OK Africa Foundation. It's a youth-led organization in South Sudan. I'm also a member of the South Sudan Youth Organization Coalition. I also sit in the National Constitution Amendment Committee as a youth representative. It's a pleasure that I've given this opportunity to share the South Sudanese or South Sudan experience. Next slide. So looking at the grassroots initiative in the fight against COVID-19, as you all know, South Sudan, first we didn't have a case of COVID-19 until mid-April. That's when we registered our first case of COVID-19. As it stands now, as of today, we have registered 74 cases of COVID-19, and we have 2 recoveries, and we have 0 deaths. That means we have 72 active cases of COVID-19. Uganda, which is neighboring us, have around 98 cases of COVID-19. Kenya is ranging around 534 cases of COVID-19. So the cases of COVID-19 in the region is rising. Apart from Burundi, that is, I think they have reported 15 cases of COVID-19. So in South Sudan, we came up with a grassroots initiative because the concept was that the COVID-19 is not an African issue. It is something that affects the people in the European countries, China, and then United States. So what we did was that we had to use our traditional means of passing information. So we became so innovative in a way that we loaded a small microphone, which is put on a bicycle, because we have to practice social distancing, and it is difficult for you to gather a lot of people into one place. So we had to pre-record the message and put it in the bicycle, and then of course we try to move around the communities to be able to sensitize the communities, and this way we were able to reach to a number of people, thousands of people in the rural communities, because it's not easy for you to use either vehicles because of the roads or infrastructure. So we use bicycles as one of the means of passing information, which is the traditional way that we have. And then we also translate these messages, because COVID-19 it is not in a local language, so we had to be able to be innovative to package our message in the local languages, so that when you speak to the people in the grassroots, they're able to understand the message. For example, when you say hand washing in English, they're not able to understand, so we should be able to say hand washing in our local languages. If you're talking about social distancing, there have been issues about either social distancing or physical distancing. So we had to package our message in the local languages. And then also we have a higher rate of illiteracy. So we had to be very creative by using pictorials. So we do a lot of drawing where we get the cartoonists and they try to do some drawing in terms of how to wash your hands, how the washing of hands look like, and all this kind of drawing, so that people are able to really understand. And then we also provide hand washing equipments to the local communities, because of resources they could not be able to afford it. So we try to provide those hand washing facilities to them. And then we also work with the traditional leaders. As you know, in African settings, most of the people listen to their traditional leaders so much. So we have to engage the traditional leaders. We have to engage the religious leaders so that they're able to pass the message that there is already COVID-19 in the country. So people need to adhere to the health rules and regulations that have been given by the Ministry of Health and the World Health Organization. We also try to advocate and lobby for community-friendly policy. As you know, the issue of COVID-19 has come with a lot of regulations. Governments are coming out to regulate a lot of things. So we have to ensure that those policies that government is coming up with and those rules and regulations that government is coming up with, it has to be community-friendly. For example, it was through our advocacy that the government had to shut down the Juba International Airport. It was through our initiative that we were able to say, look, we want our farmers to continue farming. It was through our initiative to tell the government that you are not implementing the rules and regulations that you are put in place. So we always advocate that we must have community-friendly policies. And one of the things we have been talking about is that people have been saying, okay, we have COVID-19, but you lock us inside. How are we going to survive in terms of food? So you're chasing us inside. We're going to have another COVID-19 inside our houses, and which is hunger. So we are also giving government some policy frameworks and some policy recommendations. What needs to be done, because what worked well in the United States and other countries may not work better with us, because our economy is not working so well, and we are not even being engaged in farming. So it is difficult to even provide food for the people. So we said you must have a local context and analysis if you are going for lockdown or partial lockdown, you need to look at really preparing the country into that stage. Next slide. And then, of course, with this, there are challenges, public health challenges in the fight of COVID-19. And what I think is the behavior attitude of the local communities. Up to now, some people still believe that COVID-19 is a joke. People still believe that there's no COVID-19 in the world. So the behavior attitude, and this thing is coming to change our society, how we behave. It's because sometimes we behave in a communal way. We want to work as a community. We want to do our things as a community. But the COVID-19 has come for you to stay by yourself. So the behavior attitude of the people has really affected the fight against COVID-19. And then ignorance. We have the highest rate of illiteracy. So people are still ignorant. If you're talking about COVID-19, they still think that this is a disease that either in China or United States, Spain or Italy. So people still believe that this is not something that can kill. And there's a narrative that COVID-19 cannot kill Africans. So that ignorance of people not having enough information about COVID-19 has really affected the fight against COVID-19. And then lack of public policies and legislation. Most of the countries, including South Sudan, we don't have a public policy, public health policy, or legislation that regulate our public health. So this, most of the governments in Africa, especially in South Sudan, we are struggling with the public health issues. How do I address them? Because we don't have a policy, we don't have a legislation that will be able to guide. How do you enforce the social distancing? How do you enforce all these rules that we have put in place? There is no legislation. If you take somebody to court, under which jurisprudence are you going to sanction this person, or how do you make this person accountable? So you see, most of the countries in South Sudan, we are now crippling to see how we can be able to come up with a public policy document that will be able to assist us. Then the other issue is about, of course, can I go to the next slide? Just lastly, I want to talk about opportunities.
Yes, and then we need to wrap up and go to the next speaker.
Okay, thank you. So, So under opportunities, I think I just want to reinforce one thing. I think under opportunity, I think with the COVID-19, there's lockdown in most of the countries in Africa. South Sudan is one of the countries. We have seen that governments have started to reconsider or redirecting investment on health. And these are the opportunity for us to, so that when we do our advocacy, we emphasize on government that they need to invest in health, because a lot of the governments, for example, in Africa, they don't put money on health. They rely on the donor money. Thank you.
Thank you very much. Our next panel focuses on place and segregation. And the first presenter is Marianne Mandache.
Hello, everybody. Thank you for inviting me. So I'll be speaking a little bit about the situation here in Romania with the Roma people. The Roma are a minority in the country of Romania, roughly about 10%. So our NGO, Romani Cris, next slide please, has been documenting human rights violations for the last 30 years or so. And we also created, among other things, the occupation of Roma health mediators, which are Roma women generally, who act as a liaison, as a contact between these impoverished Roma communities. Roma are among the most discriminated against and among the most impoverished groups in Europe, and probably even in the world. These Roma health mediators act as a liaison between them and the health authorities to improve access to health and to eliminate discrimination against Roma people. The current crisis of COVID-19 has brought us quite a few challenges. And one of the main challenges is that we have seen basically a lynching of the Roma in the media. So it's a mediatic lynching with increased racism in the public domain, on the internet, on major journalists, TV stations, and major politicians. So there are a lot of racist speech presenting Roma as antisocial, violent, as not respecting the social distancing legislation and so on. The president of Romania a couple of days ago has had a very racist statement. It's the fourth time he's having a racist statement against the Roma. The 3 times before, he was made those statements when he was actually president. Now he joined the chorus, and the pressure against the Roma is quite strong. A lot of the Roma have been abused by the police in some communities by the use of disproportionate force. There were people who were beaten and even tortured. Fortunately, we were able to visit a few of those communities. Now, we could not visit all of them because of the restrictions that are currently in place. We talked to some of the victims, and we documented those violations. The other issue that was presented during this crisis is that, unfortunately, the government did not think much about helping the most vulnerable people. So what they did was introduce this technical unemployment benefit, but that only works for companies who are affected by the crisis, and it's only in the benefit of employees who are having legal contracts in force. That is not the case for the Roma, for example, who are collecting scrap metal or other informal jobs. We've heard that earlier in other parts. There is no help for these people. Even worse, if they go out, they have to have an employment statement from their employer, and they are unable to produce that, and a lot of them have got a lot of big fines, up to 4,000 euros for such a thing. The other issue for lacking that statement, the other issue is that they did not have access to basic utilities, especially water. And as we know, the health professionals have clearly told us that washing your hands is a strong preventive measure. But if you don't have access to running water, to clean water, then that's a big problem for you to protect yourself. And that is the case for a lot of Roma throughout Europe, also in Romania. Another issue is that we've seen in Romania, and I think that was the case in many countries in Europe also, such as Italy, a very poor protection for healthcare staffs, for doctors, for nurses, and so on. And more concretely, in our case, for the Roma health mediators, which are sort of a paramedical occupation, and which do enter, including in these times of crisis, they do enter in contact directly with a lot of individuals because of preventive measures that they are supposed to do in the Roma communities. Next slide, please. So our, let's say, lessons or whatever, innovations or whatever you want to call it, or reconfirmations of certain statements previously concluded, is that it needs to be protested. So the protests that the police is doing, that the authorities are doing against the citizens are much worse and more often in these times of crisis, and you need to protest it, even if it takes more courage now, because the government in Romania, for example, now is militarized, and there was a state of emergency, and they derogated from the European Convention of Human Rights. So the context is a bit destructive for human rights, but you need to protest. That's a major issue. And we did that. We even asked for the dismissal of the Minister of Interior for all the abuse against Roma people. The other issue is that we did use technology much more than before. We made videos with people who were beaten up by police. We exposed those wrongdoings. So we use technology more than we used to do it. To the detriment of written statements, probably. The other issue is that we need to litigate, because unfortunately authorities still remain silent to the needs of the most vulnerable groups. So we need to challenge that in court, and we are doing that. We are currently working on filing complaints, and that's something that needs to be done to address this. authorities did not address the.
We can move on to the
Yeah,
next.
just two very short points. So the authorities are not addressing the housing segregation and the lack of access to utilities as a preventive measures, and they should do that because that's a prevention for COVID particularly, but also for many other health hazards. Access to running water, to sewage, and so on. It's a health preventive measure, and the government, even in this crisis, is being silent to that. And the last issue is that in Romania, part of this racist speech in the press is presenting certain individual cases of Roma people who are not respecting distancing measures and generalizing that to the entire Roma community. And it is not only the Roma that don't respect the social measures, it's also Romanians, it's also Hungarians or other groups. It's just that they put a focus on Roma and they make it a racial thing, and it is not. And this is why we consider that to be racist, and we are fighting it the best we can. Thank you so much.
Thank you for your work. Our next speaker is Ax Notiwala.
Hi, everyone. Yeah, my name is Akolile Notiwala, and I am a member of what is called the Khayelitsha Community Action Network, which is part of a greater network called Cape Town Together, operating within the city of Cape Town in South Africa. Also the General Secretary of a social movement called the Social Justice Coalition. Next slide, please. So Cape Town Together is a network that was launched in March 2020 as a rapidly evolving community-based response to COVID-19. And it's a network that is growing every day. Next slide, please. So the network is made out of thousands of volunteers and neighborhood-based community action networks, normally referred to as CANs. And so I'm a member of the Khayelitsha CAN. I think it's important to mention that Cape Town, as many other cities around the world, is an extremely unequal city. And also geographically and racially divided. And so it's important to understand that the work that Cape Town Together is doing is happening within this context. And so what you see in the slide is a community action network. So there are logos of community action networks in different localities. And these are CANs that are there to inspire, promote, and support ordinary people in every local community to organize and establish and grow CANs. And these are CANs that will be able and continue to enable hyper-local collective responses to COVID-19. And I mean, on the 10 points that we have there are the principles and ways of working for the CANs. So the network in itself is not a registered organization, it's a loose network. And these CANs are self-organizing and taking action within their own communities, as well as reaching out to other communities. And a number of CANs now have been started outside of the city of Cape Town in other provinces across South Africa. And some of the important work that is done through CANs, they exist to help to relay accurate information to communities, supporting the most vulnerable and high-risk residents, and share ideas and experiences, learning and resources for community action with others across the city. And some of these activities include distribution of pamphlets or information for awareness for people that would not necessarily get the information through the internet because of high internet costs and lack of accessibility to the internet. They also help in distributing food as this COVID-19 has has also shown us that food insecurity is a huge thing to look into. There are resources that are being shared with wealthier Cairns. So poor and working class Cairns are partnered, as you can see in the logo. The CBD Cairn is a wealthy Cairn. It's a wealthy residential area, and Khayelitsha is a poor and working class community. And some of the Cairns have started soup kitchens in their communities to be able to feed those that are in need. And all of this work is done while following and encouraging safety precautions. And I think we believe that the work that government has to do can never do it alone. And therefore, during this pandemic, we're trying to work with government. But that doesn't mean that government should not be criticized. Next slide, please. So, I mean, the reality is that COVID-19 and the regulations and restrictions that have been issued by different governments will have a serious impact on every family in every community. But this will not be the same in all communities, and we've seen that in Cape Town. The most vulnerable, those from poor and working class families, especially those living in informal settlements and rural areas, are struggling and will continue to struggle the most. And so what you see in the photo is a protest just before the lockdown in South Africa, where residents of informal settlements were protesting for water because they did not have water. And so these are struggles that some of the Cairns continue to face. There are issues of homelessness and evictions that my Cairn has tackled, for example. Issues of food insecurity across all Cairns. And this raises issues around ideas on basic income grants in our cities and in our countries. And lastly, we also assist in monitoring and reporting police brutality, because with the amount of police that are there to enforce regulations and the army, we've seen people being violated, and there are also reports of people that have died as a result of police action. So as much as at times we support the work that government has done, that doesn't mean we shouldn't continue being critical while we're supporting government in other initiatives. Because structural inequalities and injustice are laid bare at this time. And so we must all continue challenging them. Thank you.
Thank you very much. Just a reminder that if you want to hear the audio in English, click the interpretation button at the bottom of your screen and select English. You can do the same para español y portugués. The next speaker is Givania Silva.
Well, good afternoon, everyone. I'd like to thank for this invitation, and to Francisco, who has invited us, invited the National Coordination of Quilombos in Brazil. My name is Givania, as it's on screen, and I'm a Quilombola member, and I also am a member of this organization, which is done and coordinated by the National Quilombos in Brazil. And we have just had our anniversary of 24 years now. And we would like to say that for us from CONAC, it's been quite hard to deal with this matter of COVID. But I'd like to explain before that what are Brazilian Quilombos. And they are groups which have been formed from the resistance processes against slavery in Brazil. And in Brazil nowadays, we have the estimate that we have around 6,000 Quilombos around the country, being that the national government still does not, or has never actually carried out a national census so that we can actually know how many are we. So, therefore, formally speaking, now we are around 4,000 Quilombo communities spread around the country, but that doesn't mean that we are only that number. COVID in our lives and the lives of Quilombo communities has come as a manner of demonstrating a reality that has already been quite clear and centrally speaking, which is the absence of public policies, which is the structural racism, which is structured inside institutions and governmental bodies. And COVID comes as a measure, as an action actually, that has even brought a higher light into this fact. And this is a picture of our national encounter, a women national encounter. And I belong to that group. It's a collective that works with women collective in Brazil. And another issue that it's important for us to highlight is that we've been going through, and some of the panelists have already spoken about it, and Lucy, if I'm not mistaken, we are going through a moment of extreme violence, institutional violence, racism, which has been led, unfortunately, by the President of the Republic, who has already, during his campaign, announced that he wouldn't work for indigenous populations, neither for Quilombo communities. And even though he was elected, he has been working above all, and he has been talking about his hatred and his racism. And even though he does that, the government keeps on going. So he instituted all the policies of the governmental bodies. And on the other hand, he has already instituted since 2016, when we had the coup, the national coup, the government that he took over began disassembling the structural policies that had been constructed and built mainly throughout the former years, while we had the Labour Party in force. And the people who actually became members of public policies, and they were incorporated in our state as a subject of rights. And the governments, ever since the coup was implemented, they have been disassembling all the rights that had been achieved previously. And as Bolsonaro has been doing lately, the budget and the policies that were implemented on our benefits have been disassembled. And certainly, this is going to impact, and it's already impacting, because we have COVID that has already reached 8 states of our republic. And up until yesterday, we have 17 people have died because of COVID in our communities. And we have a huge problem, which is Quilombo communities in Brazil. We don't have any body, governmental body, that monitors the policies which are made towards our benefits. And this monitoring has been done by ourselves. And we are trying to call the leaderships around Brazil. And as you know, Brazil is a huge place. And this has generated many difficulties, without even mentioning that we have a huge problem regarding during this moment of COVID, which is the question of color and race. And
Givanya,
which has to be...
we need to wrap up soon to move to...
A gente tem que ir encerrando agora, por favor, Giovanna. Okay. Yes. Okay, just to wrap up, I'd like to say that I won't have enough time. I'd like to bring other information, but I'd like to talk about our opportunities, which are, I'd like to outline a few, is that on the one hand, we have been made clear the racism of the public policies of Brazil. But regarding the articulation we have been having the possibility of organizing ourselves in networks, and we have been increasing our reach. And we are using certain tools in terms of technology that we didn't used to use, and now they are in place. And I'd like to say just at last that it has been very difficult because it's hard for people to stay at home when the government itself is telling people not to. So it's very hard for people to ask people not to do or to access the benefit of minimum income if they don't have technology to do so. So it's hard to keep on doing constant collaborations when actually people don't have water at home. Not to mention all the other obligations to their families. So thank you very much.
Thank you very much. So now we'll move to the question and answer period hosted by Francisco Ortega and Kelly Ray Knight. If all the panelists could turn their video on, that would be wonderful.
Hello, everybody. As we wait for everybody, Lily, also if you could turn off the screen share so we can get to a big view and we can see everybody's faces. Oh, brilliant. Thank you. So we don't have a lot of time, which always happens, but I'm so pleased that we spent most of the time being able to have everybody share. So Francisco and I are going to try and ask a couple of quick questions. We won't be able to get to everyone, but we'll do our best and then close up as we finish. So I wanted to go back to some of the comments that were made in the beginning of the panel in the reproductive justice section. You mentioned that weakened systems are always gendered systems. And Monica McLemore also pointed out that, that reproductive health has become a canary in the coal mine in the context of COVID. And Swathi, I wanted to actually direct this question to you because you also, as many of the other speakers pointed out, that the expertise is already there, that we have communities who know what to do and how to take care of their communities and how to respond. And I wanted to get your insight on how we can redistribute resources toward those communities in the context of COVID so that we can make sure that some of the structural changes we're seeing happen more rapidly, like telemedicine, for example, as one, can stay. And what are your ideas for redistributing resources to maintain those structural changes?
Well, I think the first thing is to know where those resources are and what those innovation solutions are, and that's what we're doing with the Global Task Force. I'm just so humbled and so grateful for all the things that you're doing all over the world, really. And I really hope you will join. I put it in the chat. I hope you will join the task force. You can join for any level. If you're too busy, we understand you're on the ground. We can just keep you in the loop, or you can join one of the committees. But what we're trying to do is create a central open access repository that will be available on mobile phones, that will be available without connectivity, that will be available also for people who have internet for telehealth, that helps you locate yourself. Maybe you're rural, maybe you're indigenous, and you don't need to know what can be done in New York City. You need to know what can be done in your village. And so we will connect you to those appropriate resources that can be adapted and our templates, so that, for example, what's being done in Sudan that Wani Michael described could be done, with bicycles in another jurisdiction, and maybe they hadn't heard about it. What's being done in New York with telehealth doulas could be done somewhere else. What's being done with human rights tracking of abuses could be done for the Roma people. We have, many people are doing things that when I listen to you, I know other people are doing something that could be helpful, and we're trying to get that all accessible to you through this repository.
Great, thank you. And we will post more information about that on our website. Francisco?
Okay, I want to ask a question to Gabriela. I think she understands English, otherwise I can raise the question in English and then in Spanish. It's a question about the situation in Argentina, because unlike governments in Brazil or in the United States, the Argentinian government have been very supportive to public health measures to fight COVID-19 in the country. So I would like to know, from your perspective of someone working in primary healthcare, whether this does make a difference in fighting the pandemic, that you have this support. Do you have this support from the government, and does it make a difference? and how the economic crisis in the country is affecting the work in primary healthcare.
Unfortunately, Gabriela had to head off to work, so she's no longer on the panel.
She's not longer? Okay, I have it's time for a second question.
Okay.
If she's no longer there.
Yeah, we have about a minute.
Organizers.
Yes.
Yeah.
Okay, question. Then a question very quick, maybe to Anna and. Okay, a question to Anna. How do you think the current situation with the government, because Bolsonaro is not using the pandemic as other authoritarian leaders to fight opponents like you have in Hungary or you have in India, etc. Do you think does make a difference when dealing with indigenous health issues in pandemic?
Most certainly, because one of the main, as Giovanna said, one of the main points for this government is to take over indigenous territory. So it's very important for the economic and development plan to access indigenous territory and their resources. So in this context, all the indigenous health policy as the other indigenous policy, they are being weakened. So the foundation that should protect indigenous people actually is also weakened. And so what we see is that the response will be not as strong as he, but the other problem is that the level of violence and menaces that they are having the territories, it's increasing. So they have to face COVID, they have to face protection of their territories, which include invasors. Those invasors, they are bringing COVID to the territories. So for sure, the perspective of the government related to indigenous people will affect directly and negatively the indigenous health response for this pandemic. So we have we have a very delicate situation because we don't have an interference, the other institutions in health in indigenous health systems. So we do need to manage this political situation, which I'm saying as Fiocruz, which is a governmental institution, for instance. So to take over and to advocacy for indigenous peoples in this context, sometimes is read as a confrontation to the government. So it's a very delicate and a very tense situation for this front line.
Thank you, Ana Lucia. We're gonna have to wrap up, and I'm so sorry to have to cut the Q&A short. But Tinashe and I are just gonna have some closing remarks. Tinashe, are you there on video? Everybody else can turn off their video. Yes, great. So I wanted to give you a chance to reintroduce the Global Campaign Against Racism.
Okay. So thank you, everyone, and thanks for everyone who took time to join the call. And we're really impressed by the work that's being doing and how this situation has brought us together. So just a quick outline in terms of how the campaign works. So we have different chapters in different countries. So meaning that anyone from any country can form a chapter in the country. So the network of chapters we then work around in terms of mobilizing resources, in terms of skills, and working together along how racism and racialized capitalism manifest in your own setting. Because this is an acknowledgement that the situation in the US is different from the situation in India, is different from the situation in Europe, the situation in Africa. So the idea is for most of the campaigns to be led by local people on the ground, then build global solidarity across networks. So for more information, do visit our website, or you can email, or you can send an email then on how to support the work or how to become a chapter. Yeah, thank you.
Absolutely, thank you so much, and thank you for your co-sponsorship.
Yes.
We're out of time, but I want to redirect everybody as a way of closing this amazing panel today, and rethank all the panelists and my co-organizers for this incredible work. Please visit structuralcompetency.org. We'll have the recording up for this and also our previous two panels that addressed first response and basic needs and medically marginalized populations. that happened in the previous several weeks. And please sign up for our listserv and join us in this collective effort to implement and sustain structural changes in the era of COVID-19 and beyond. Thank you.
We'll also be posting on structuralcompetency.org, not just in English, but we also plan to post translated, interpreted videos as well. Thank you very much.
Thank
Sorry
you,
for
everyone.
again, Kelly.
No worries.